You guys won't believe this. This is his 16th appearance on the webinar series. So that means about 8% of all webinars have featured Dr. Randy Resnik. And you know, the thing is that we get great attendance. People really enjoy hearing from Dr. Resnik. So we're just going to keep bringing him back. He's the director of the Resnik Implant Institute, which is the premier implant training program in the United States. He's the author of 2 recent textbooks, the 4th edition of Mish's Contemporary Implant Dentistry and Avoiding Complications in Implant Dentistry, which I understand is being made into a feature film. Is that right, Randy?
Yeah.
And
amount of time we spent on it.
Right. He's a frequent contributor to Chairside Magazine, writing some of the most popular articles on everything from implant occlusion to socket preservation and membrane grafting. And all those articles are available for reference on our website. His topic today is so important. Everybody's going out there and getting cone beam imaging equipment. And a lot of us don't really have the training to read these images and make sure that we get all the right information from them, particularly and how it'll affect our surgical procedure. So we brought Dr. Resnik back to teach us about reading cone beam CTs, identifying mandibular structures related to oral implantology. So Randy, take it away. It's all yours.
Okay, great. Thank you very much, Neil. It's great to be back. I think it was about a year ago, I talked about the maxilla. So today we're going to talk just about the mandible, any vital structures that are related to any type of surgical or prosthetic procedures that we'll be doing in implantology. So if we look at the summary of how I'm going to do this today, I'm going to break up the anterior and the posterior. And then what we're going to do is go over radiographic appearance of these vital structures. I'll talk about the clinical relevance, how it actually relates to the procedures that we're doing. And then we'll talk about issues that you might have, complications, or how to prevent complications with these particular vital structures. So I have a lot to go through, so let's get right into it. Let's first start at the anterior mandible. Now, the anterior mandible, if you go back to the 80s with the Brandmark technique, the reason why Brandmark selected implants in the anterior mandible was because it was a safe area. And it was thought if you stay between the foramens, there's really nothing bad can happen. However, what we have really seen, especially with the advent of CBCT scans, there is some vital structures and anatomic variants that can play a significant role in implant complications. So I'm going to go over a couple of these, and we'll first talk about the mandibular lingual vascular canal. Some people call it the MLVC, and it is right in the midline. So it's right where a lot of times we're placing an implant, and in probably over 50% of the patients, you're going to see this radiographically on a CBCT. So this is a cross-section image, and you can see by the red arrows, there is a radiolucent canal that comes in from the lingual, and it transverses all the way almost to the buccal plate and then all the way up to the crestal ridge. So it's a radiolucent canal. It's in the midline most commonly. And where it comes in at is this area right here where I have the white arrow. Okay, that is called the lingual foramen. If you look at it radiographically on a panoramic CBCT, you'll see a opacity, which is the cortical bone around that foramen. And then on an axial scan, you'll see a little radiolucency, and that usually opens up into that canal that transverses through the anterior mandible. It's usually located superior to where the genial tubercles are. Remember, that is where the attachment of the genioglossus muscle is. So why is this significant? Well, if we look at some of these cases here, it can be rather large. Usually the ones that cause issues are more than a millimeter in diameter. So you can see this example where in one image, it's coming through the lingual plate and then going superiorly, but then another branch goes out towards the facial. So this position is really relevant for some of the procedures that we'll do. But let's first talk about what's in this radiolucent canal. Why, as an implantologist, you need to know about this? Well, what happens is the lingual artery has branches off the lingual artery called the sublingual arteries, and they transverse the inferior border of the mandible, and they actually anastomose in the midline. So you have the right and the left sublingual arteries that anastomose into this area, and then it goes into the actual, through the cortical bone into the trabecular bone. So what is significant about this anastomosis? Well, number one, this is a vital structure and there's a nerve artery and a vein to it. What are we worried about? Mainly the vein and the artery. So when we do a procedure such as putting an implant in the center position, which what we call the C position. Why do we want implants in that C position? Usually to increase our AP spread. So we're on cases that we're placing 4 or 5 implants in the anterior mandible, we're usually using that center position. So we're right in that same position where this anatomic area is. So what can happen? Well, if you drill through it and you place an implant and perform an osteotomy in this area, you're going to sever the blood vessels. And usually what you'll do is get osteotomy bleeding, okay? This is not going to be a gusher. It's not going to shoot out at you. It's just going to be a lot of oozing. And some of these will really bleed. It all depends on the diameter of the artery and the vein, but some will really bleed. So when we look at treatment, everyone thinks, well, put pressure on is the best. So bimanual pressure is one that you can do. If you get a 4x4 gauze in your index finger in the superior aspect over the ridge, and then your thumb under the inferior border, and you squeeze together, that can stop the bleeding. However, the bleeding is within the confines of the mandible. So the easiest thing to do if it's really bad and it becomes problematic is you take the last drill that you used and just put the drill in, okay, and let it clot off. Intraosseous bleeding is a lot better than extraosseous bleeding. When you have bleeding outside of the bone, that's bad because then you have to get access to tie it off. Inside the bone is rather easy, or you can just put the implant in. And usually this will just clot off and not a problem. So this midline vascular canal, a lot of people will talk about actually avoiding it. And there is really no reason to avoid it, in my opinion. You'll see here, this is one example of someone who avoided it. They placed the implant about halfway into the bone because they didn't want to transect this area. But again, it will bleed on you. It depends on the diameter. And however, it's easily resolved by placing the implant in, the direction indicator, or a drill. Our second area, anatomic area in the anterior, is what is called an hourglass anterior mandible. Now, we're used to, for years, we just use Panorexes, and we would look at, okay, we have a ton of bone here. We can do whatever we want. And we really never thought about the third dimension. However, with CBCTs, it gives us the third dimension so that we can see these variations in the morphology of the bone that can play a huge role in our surgical procedures and our implant placement. So that is called an hourglass anterior mandible. Now, if we look at studies show about 4% of patients will have some type of constriction. And it can be a facial, lingual, or an hourglass constriction, but it's an abnormal constriction and it compromises the width of the bone. So on this cross section here, you can see we have plenty of width of bone. However, when we get down here, it's very, very constricted, and that becomes problematic. Why does that become problematic? because if we try to place an implant there, we're going to perforate, and we never want to perforate. So if you can remember one thing from this lecture today, never perforate the bone. There's nothing good that can happen from it. Now, if we look at why this particular area is very relevant, if we perforate in that anterior mandible, we have some bad blood vessels, okay? First of all, we have the submental artery, which is a branch of the facial artery that comes all the way up to the cuspid area in a lot of patients. However, we also have those sublingual arteries that anastomose right in the midline, and usually they're very, very close around the cuspid area. So right outside of this bone here, where you perforate, you have a blood vessel, and it's a sublingual or a submental artery, and that will become problematic. Why does it become problematic? Because when you perforate like this, you can cause bleeding. And when you get bleeding down here, it's very hard to control. So here in this patient, this is one that an implant was placed and the patient had a post-operative bleed. Wasn't bleeding at the time of surgery, but went home. And because of the aggressive threads on the apex of these implants that we use now, you can sever these arteries and these blood vessels and cause problems. So this patient ended up with an indurated mass in the inferior border of the mandible, which became infected and became problematic. Now, however, worse things can happen. So if you look in the literature, there's probably 100 case studies that will talk about placing implants in this anterior mandible and ending up with a life-threatening situation like this, which is a sublingual hematoma. So what is a sublingual hematoma? What happens is the blood you'll have a severe bleed in the sublingual tissue. Because of that, what ends up happening is that sublingual tissue will get larger, it raises the tongue, and then it shuts off the patient's airway. So if this would happen to you, because there are many, many cases where it happens almost instantaneously once you drill through, you want to reposition the patient. First thing is you bring them from a supine position and you put them upright. The reason is you want their head above the heart. The second thing you do is you pull the tongue straight out. Whether you get hemostats or these are called young forceps, which are used in anesthesia, you pull the tongue out. What that does is that will actually open the airway and also put pressure on the hyoid bone to at least minimize the vessel bleeding. And then certainly you're going to call 911 in this situation. So you can see where going outside of the bone can be very problematic and lead to a life-threatening situation. Now, there is also doctors that will look at these constriction mandibles, and how do they treat it? They treat away from it. So I want you to look at these cases and remember, every patient doesn't need an implant. And these patients anatomically are very difficult. You have to do very aggressive bone grafting. The way that we usually treat these patients is we'll do a bone graft on the lingual and on the buccal. So usually they're block grafts. They're rather aggressive grafts. However, you don't want to put the implant in a non-ideal position because then you have to put a prosthesis on it. So again, if the patient does not want to have bone grafting or that's not going to be able to be completed, then the patient's just not a candidate. What you don't want to do is go outside the bone and potentially have a life-threatening situation. The third anterior anatomic variant that I want to talk about is something that I probably get a phone call once a month for. And this is a doctor will call and they'll say, Randy, I have an anterior loop that goes all the way to the midline. And if you can see, this is the mandibular canal. And here is the mental foramen. And then this is called the incisive canal. Now, the only time you're going to see this is if teeth are still in the anterior mandible or if they're recent extractions, because what these are nutrient vessels that go to the actual teeth. So off of this area, which is incisive nerve, artery, and vein, it goes to all of the anterior teeth. Actually, will also go to the first premolar. So what does it look like? It's a radiolucent canal, and it's in the interforaminal area. So it's between the foramens in the anterior mandible. Now, it can be extremely variable. You can have this radiolucent areas go all the way up to the ridge, or they can just be like this. It all depends on when the teeth were taken out and how fast those are necrosing and become necrotic. So if we look, this is an axial CBCT scan. So this is the mandibular canal, inferior alveolar canal. This is actually the incisive vessels, and then this is the mental vessels. So these two travel, they're coincide with each other. The mental nerve goes through the mental foramen, the incisive nerve goes through the incisive canal and innervates the anterior teeth. So on a panoramic CBCT, you can see it here and here. Again, remnants, usually this becomes necrotic in time after the teeth are taken out, but sometimes you'll see them up to a year after the teeth are taken out. If you look in a cross section, some of these canals are really large. So this will actually look like the inferior alveolar canal. However, this is actually the incisive canal because it's between the foramens. And again, that is, we'll get into the relevance of it here, but this is an area that we often place implants. So this anterior mandible, again, is a common place for all on X or overdenture procedures in the mandible. So when we plan it out, we'll often see this incisive canal, which is misinterpreted as an anterior loop of the mental nerve on, it's very common. So what experience do we have in this? Well, when in the early days, we didn't really use particulate grafting, we would do symphysis grafts. This is where we would augment bone. So we would go below the apices of the teeth, we would drill out a block, and then we would build up jaws with this autogenous bone. And I've done thousands of these, and I'll tell you, I've really never saw much bleeding. Even though we went through this incisive canal, there really wasn't a lot of bleeding. Usually it just oozes like this, and it's usually more like this. So that will tell you that drilling through this is not really a issue. Now, let's say that you drill through it. You're going to also get that osteotomy bleed. You can do the bimanual pressure. You can insert the drill or insert the implant, and that will clot it off. So that is usually the treatment. So again, a summary of this anterior mandible is an intraosseous bleeding issue is not bad, usually not bad. It can be controlled very easily with hemostatic agents, pressure, and or placing the drill, implant, or direction indicator in. Going outside the bone with a drill, with an implant, is very dangerous, and you have to be very careful with that. So that is the anterior. Now, let's jump into the posterior mandible, because this is an area that is a lot more problematic and can be a lot more dangerous with increased complications. So the first area that we're going to talk about is the mental nerves or the inferior alveolar nerves. So this is how we used to do procedures when we placed implants. We would always identify and basically dissect out the mental nerve or the mental vessels. So that would give us basically our boundaries for where we're going to place implants in that anterior mandible. Now we have CBCTs. And what a lot of people believe is the inferior alveolar nerve comes in from the lingual aspect of the mandible, and it transverses anteriorly through the mental foramen, and that's it. That's actually not true. So a lot of anatomy, if we go back to the early days of anatomy, Carter in 1970 actually documented the three nerve types. You as an implantologist have to know this because there's a type 1 nerve. What is a type 1 nerve? That is where the nerve goes from the posterior to the anterior, but it hugs the roots of the teeth. So basically, it is right below the apices of the teeth. And you can see this endodontist that it is right below the apices of the teeth. And here is filler into the canal, which is not a good day at the office. The type 1 nerves are the most dangerous, most common to be traumatized, especially with immediate implant placement, which we'll talk about in a minute. A type 2 nerve is the most common nerve, and usually it's a little bit below the halfway mark. If you would evaluate the mandible vertically in thirds, it's usually in the lower third, and this is the most common with branches off to the teeth. So type 2 is the most common. The best for you as an implantologist is a type 3 nerve, because the type 3 nerve hugs the inferior border of the mandible, and that gives you the most host bone to place an implant. So again, the three types: type 1, type 2, type 3. 3 is the best for the patient for a implant placement. Type 1 is the worst. Type 2 is the most common. So when we look at the actual course of the nerve or of the vessels from the posterior to the anterior, the inferior alveolar nerve enters the mandibular foramen by the lingula here on the lingual aspect of the ramus. And as it courses anteriorly, a lot of people believe it is like halfway between the cortical plates vertically, and then it's in the center buccolingually. However, that's not true. As it comes forward, it's extremely variable on where this nerve is. As I just showed you vertically, it could be right by the apices. It could be right here, which is class 2, type 2, or inferiorly is a type 3. So the bottom line, I don't want to bore you with a lot of studies, but there's been a lot of studies on this, especially I've done probably 2 or 3 myself. And the course of the nerve is extremely variable. In a buccolingual position, superior and inferior, as it transverses from the posterior to the anterior. Now, why is that important? Because you have to know where that nerve is when you're placing implants here. And there is procedures out there or techniques where you try to go lingual to the nerve or buccal to the nerve, which is very, very difficult. And that ends up with a lot of morbidity. So ideally, the best way is you stay above the nerve, usually 2 millimeters. Now, the inferior alveolar comes here, and as it comes forward, it actually branches into 2 terminal branches. One is the mental nerve, and the second is the incisive nerve, which we've already talked about. So if you look at the anatomic names of these nerves, the inferior alveolar nerve, like people will say, if they run into a nerve impairment in the mental foramen, they'll call it an inferior alveolar nerve injury. It's actually not. It's a mental nerve injury, because the inferior alveolar nerve, it goes up to about the first molar area. At that time, it breaks into 2 terminal branches. The mental nerve, which then has 3 to 4 branches, which go to the anterior gingiva, the chin, and the anterior lip. And then the incisive branch, that's the mental nerve. And then the incisive branch goes to the anterior teeth. So why is this important? Because you have to understand where this nerve is anytime you're working around it, whether it's anterior, posterior, or right over top of it. So if you look at this is an MRI, this is the mandible, the cortical bone of the mandible. This is the neurovascular canal. So let's look inside the neurovascular canal. The inferior alveolar canal or mandibular canal usually has a cortical covering. The nerve fascicles, which are made up of many, many nerve fibers, are right below it. Right above it is an artery and a vein. And there used to be a technique, this is back in the 1980s, where the technique was you drill until you get into the superior aspect of the inferior alveolar canal. And once you get bleeding, you stop. You stop short of the nerve fascicles, which was just, it made no sense at all. And I'm glad that that came and went, and very few people did that because it usually ended up with nerve difficulties and or nerve sensory impairments. So if we look at the nerve here, our goal is to stay above it. So now we have interactive treatment planning. We know where the teeth are. We can place an implant. We know where the nerve is, whether it's buccolingual or in the center. Our goal is to stay at least 2 millimeters away. Most of the interactive CBCT programs now have safety zones where you can actually not get closer than 2 millimeters to the nerve. So if you try to place an implant closer, at least guided, it won't allow that because the program just won't allow that. So if you want to stay in the safe side, stay more than 2 millimeters away, and then you don't have to worry about complications with a neurosensory impairment. So what do we do when we hear this? Doc, I'm still numb. Patient calls the next day. Well, you can have a neurosensory impairment from placing the implant into the canal, or you might not have even got into the canal. It can just be very close to the canal. So there's been cases where implants have been placed close to the canal, and if there's no cortical lining like here, you can actually press or push the trabecular bone down into that neurovascular canal and disrupt those fascicles, which can be problematic. So the best thing is stay away from it. If it does happen, whether you place an implant, whether you're drilling and you get close to it, you have to treat it correctly. Number one, you just don't want to leave the implant there where it's going to traumatize the nerve. So a lot of people don't realize there's something called the Y dimension, which means if you're drilling, say for a 10 millimeter implant, the wider the drill, the greater the Y dimension, meaning you're drilling longer than 10 millimeters. So in this particular case, you can see where the implant is short of the canal, but the Y diameter of the actual drill has penetrated into the nerve canal. So the relevance of this and why I'm telling you this is make sure your surgical system, you know what the Y dimension is. Some are very long. I mean, some can go up to 2 millimeters, especially with the wider diameter drills. Most are at a millimeter or less, but it's something that you do need to know depending on what type of system you're using. So when you look at nerve damage, and I'm just going to go over this very fast because I know I'll get a question on it at the end, is what do you do? Well, it all depends on what happens. Was there axon damage or not? You can have pressure on it. You can have where the myelin sheath has been destroyed, or it can be completely disconnected, and then you get the degeneration process. So real fast, in neurology, there's 3 different classifications called the Seddon classification. Neuropraxia is this, where there's pressure on the nerve, where there is no axon damage. Axonotmesis is where you get slight axon damage with Wallerian degeneration, and neurotmesis is where you transect the nerve. This is the worst. Anytime you get Wallerian degeneration, what that means is when the nerve is transected, nerve fibers will immediately start to regenerate and try to regenerate and reconnect. However, when you get Wallerian degeneration, the nerve actually springs back, and then you get what is called a neuroma or a callus, and that becomes very dangerous or very complicated and problematic. There are three basic terms that are used now for sensory loss. Paresthesia, the new term definition is it's an abnormal sensation that is not unpleasant, meaning it's basically pins and needles or maybe like a thumping where it's not real painful. Anesthesia is the worst because that's where it's transected. There's no sensation at all. And then dysesthesia actually could be just as bad as anesthesia in that it gives you, it's an abnormal sensation that's very unpleasant. This is usually what happens after a neuroma formation. Why do I tell you all that? Because it is imperative, and I see doctors making this mistake all the time. I see it in the legal arena. They'll see a patient or they'll do a procedure, a patient will call them still numb. Well, let's give it 2 weeks. You need to see them immediately because there is a protocol. And if you just Google my name and nerve injuries, I've written probably 5 or 6 articles, at least 2 or 3 chapters on it. But you want to see the patient immediately in your office, take a CBCT. If the implant is in the nerve, you want it out, take it out. Do not reposition it superiorly. A lot of people will say that, but then you're going to have the implant in a non-prosthetic position. Also, you want this to regenerate. Neurosensory mapping is imperative, and you must give corticosteroids. That's basically standard of care. If you're unfamiliar with doing any of these procedures, then refer it, but the sooner the referral, the better. So with that being said, if you want to learn more about nerve injuries and how to take care of it, again, just Google that. I have those protocols in very well-documented procedures. Our second anatomic variant is called an anterior loop. What is an anterior loop? If we look at studies, about 50% of the patients have anterior loops. Well, what actually is an anterior loop? As I said, this is the mental branch. As it comes forward, instead of going out of the mental foramen, it actually comes forward, and that is called, that part of it is called an anterior loop. So it comes forward of the mental foramen, usually seen in type 3 nerves. So the way that you can tell is if there is an anterior loop, you have to go into the axial scan and you have to go incrementally inferiorly. So you can see here, I put a constant line. Here, you can see this is where the nerve is. As I go inferiorly, you will see that that nerve never goes anterior to the line. So this is a case where there is no anterior loop. Now, let me show you one that is. Again, I'm going to start here, go inferior. Watch, this is where the nerve is, which we've marked out. So as we go inferior, you can see, look, it's come at least 1 millimeter, 2 millimeters anterior to our line, to our anterior border of the mental nerve. That means that that's an anterior loop, which is problematic. This is the best way to tell if there is an anterior loop. Look in its sequential axial images starting superior to the inferior border. Now, what's the relevance of this? Well, we're placing, here's the nerve. We're placing an implant right in front of it. If we have a 2 millimeter, 3, 4 millimeter anterior loop, we're going to place the implant right into the nerve. So we have to be very, very careful of that. So what you don't want to do, again, is put that implant in approximation to that nerve or the foramen, because then you can end up with a nerve sensory impairment. So how do we prevent it? When we plan out the case, this is an axial scan. This is the anterior part of the mental foramen. We make our mark. Then we know we want to be 2 millimeters. So our implant needs to be, our distal part of the implant needs to be further 2 millimeters or greater. So, however, if we have an anterior loop, say up to here, say we have a 1 millimeter anterior loop, now we have this extra millimeter here. So if we place this implant, we're going to be too close. So what we need is a new zone, our 2 millimeter zone. So our new implant needs to be farther anterior away from that anterior loop. So the bottom line is just do the math. Whatever the loop is, add it to your, however you're doing, if it's guided or if you're doing it freehand, you just add that to where your safety zone position is when you do the osteotomy. Our third posterior anatomic variant is what is called accessory foramens, or what I've identified in the literature is called nutrient canals. A lot of people use these terms synonymously, but they're really different, and I'll show you why. An accessory foramen is where you have that infraalveolar nerve and or the mental nerve. As I said, the mental nerve has 4 branches. It's already branched, not here, but back here. And that is called a bifid canal or an accessory foramen. On a 3D image, you'll see actually 2 canals. Now, how do you know they're accessory foramens? Usually they're of the same size. So when you see 2 foramens of the same size, that means that those are 1 or 2, 3 of the 4 branches of the mental nerve coming through there. Incidence is about 2 to 10% of patients will actually have accessory foramens. So always look at it. The easiest way I've seen to identify them is on the 3D image. Now, a nutrient canal, it looks like a small little nerve fiber, or I call them little angel hair pasta. And these are the nutrient canals that branch off of that inferior alveolar nerve branch and go to the teeth. So these are actually nutrient branches that are sensory to the teeth. They're not sensory to soft tissue. So the bottom line is the accessory foramen, some people call double foramen bifid canal. These are sensory and they go to soft tissue where you will have a neurosensory deficit. The nutrient canals are not sensory to any of the soft tissue or the skin. They're nutrient vessels to the actual teeth. So when you look at here's the mental nerve, and I've identified just on this one, here's a nutrient canal fiber right here. Here's another one. Here's another one. So you can sever these. It's not going to hurt anything because the teeth are already gone. And these usually become necrotic anyway. Number 4, posterior lingual undercuts. Very, very dangerous area. And I can't tell you how many cases I've seen, especially recently, a violation of this. Studies show about greater than 2 millimeter lingual concavity in 80% of patients. The lingual concavity anatomy is extremely variable. You can have no undercut, you can have a severe undercut, extremely variable. What is the relevance of it? Well, if you place an implant on a Panorex or even a CBCT Panorex, always look at the 3rd dimension, because you have the sublingual fossa here. You have the submandibular gland, the sublingual gland here. You don't want to place the implant into that area. That becomes problematic. Also, you have the submental arteries. Also, you can lose an implant into the sublingual space. Here is 2 cases from the literature. One where they left the implant for whatever reason, I have no idea. Here's another one where they placed an implant, and instead of taking that, they placed another one on top of it. I don't understand that one either, but be very careful. Here's another one, implant placed, huge undercut, didn't know about it, went into the sublingual space. So the rule of thumb is I go back to never perforate. If you perforate, that gets very dangerous. Why does it get very dangerous? Because it becomes a sublingual hematoma. You can see here, this is an actual case that I was involved in. Doctor perforated, and you can see here's the tongue space. Completely obliterate their airway. So that is a 911 distress, life-threatening situation, all from going too far in perforating. You treat it the same way, sublingual hematoma, reposition patient, pull the tongue out, 911. And Be very careful. And here's a case where the doctor actually repositioned the implant more facially to avoid that. So bone grafted and or the patient might not be a candidate for implants. Number 5, osteoporotic areas. Now, this is very common in the posterior mandible. It can be in males, mainly in females. What are we looking at? Well, a focal osteoporotic marrow defect, that's a localized area. Or it could be an osteoporotic or an osteopenic patient. So when you see a patient like this, where there is almost no trabeculi, where the cortical bone has become mottled, where there's little air pockets or radiolucencies, that means that patient most definitely is osteoporotic or osteopenic. Why is that a problem for what we do? Well, here's the case where an implant was placed, good primary stability. As you know, primary stability going in the secondary stability is not as great. Implant got lost into the mandible. Here's another case study, same thing. Doctor went to uncover the implant and it's in the inferior border of the mandible. Here's another one, lost because of this one's a huge undercut and a osteoporotic area. So what's the relevance of this? That's why we teach a different protocol in poor density of bone, because we know you're going to lose the primary stability and we don't want the implant migrating, because that can be very difficult or complicated and traumatic. Okay, a couple more. I know I'm running out of time here. You will see this, and a lot of doctors don't realize this can happen or what this is. And when you look at the angle of the mandible right anterior to it, where the masseter inserts, you can have a anagonial notch depth. And what is that? Well, when you have a notch like that, that has been shown in the literature to be associated with masseter hypertrophy. Masseter hypertrophy has been associated with what? Bruxism, clenching, parafunctional habits. We know that all that is really bad for implants. Here's a study that shows patient with parafunction survival rate 5 years goes from 90% all the way to 72%. Here's a systemic review and meta-analysis. Bruxers, 2 times the failure rate versus non-Bruxers. Here's another systemic review meta-analysis, significantly higher implant failure. And what do we usually see? Prosthesis failures. So be very careful. We know the patients, when they have parafunction, they're biting, the average male bites about 250 pounds per square inch in the molar region. Parafunction patients up to 1,000, 4 to 7 times the normal. So be very careful. So when you see a patient like this, that has this notch, you have to over-engineer the case. You know that that patient, if they wore out cortical bone from that masseter muscle, you know they're going to wear out your implants or they're going to wear out the prosthesis. The last one I'm going to go over is something that you will see on a mandibular scan, and it's an anatomic variant, but it is a incidental finding that the patient should be alerted to. If you look at this, this is, remember, the common carotid, then you have the external in the internal carotid. Right at the bifurcation here, it's not uncommon for patients to get plaque or calcifications here. This is one of my patients. They look like little pebbles, and it'll be right on the angle of the mandible. If you look at the cervical vertebrae, usually about C3, you go right over from C3, that's where the bifurcation is. So when you see these little pebbles, that is an indication that that patient could have a cardiovascular event in their near future. And you certainly don't want that in the office. So usually what is taken is the physicians will get a CT angiogram to prevent the patient from stroking out. And you actually have a calcified calcium score, and that dictates if they have to go in surgically or treated by medicine. So always look at that. That's right adjacent to the angle of the mandible. So I have a couple minutes left. Let me I know that was a lot of material to go over in a very short period of time, but let me give you some take-home messages. First of all, always keep the implants within the bone. If it is an anatomically abnormal bone or site, don't place the implant. Graft it, or the patient doesn't get an implant. That implant now, because of how sharp these and how aggressive these threads are very dangerous to vessels down here. And I just showed you these vessels are very small, but you do not have access to go and tie them off. So they're very dangerous, and it usually ends up with an airway compromise. Understand the anatomy. We went over the 3 different types of nerve anatomy. You want to keep that implant 2 millimeters above where that nerve is. If it's your first case, look for a type 3 nerve. Don't do a type 1. Remember, but a type 3 nerve has a higher incidence of an anterior loop. So these are just some of the anatomic variants. I went over these today. There's a lot more of those. I would recommend, if you want to read more, in both of the textbooks and the third one coming out, there's a large, rather significant radiology chapter that goes through all of those complications and anatomic variants to help you come up with a differential diagnosis and understand that. So with 2 minutes to spare, Neil, sorry for going over a little bit.
Very impressive. Yeah, your timing is excellent. We've got a lot of good questions. If you have a few more minutes to stick around,
let's do it.
Okay, hey, great questions here. So, how do I determine the difference between the incisive canal and just an anterior extension of the mental nerve? Because obviously the contents of those 2 areas are much different.
Yeah, so you do have to distinguish those. If you look at some of the older textbooks, what they will say is you look on a panoramic image. That's where most of the studies are. But what I showed you, and I have it in both textbooks, a step-by-step way how to do this, you have to look at it in the axial images. The axial image, because you actually transverse, you draw the nerve first, then you go into the axial image. So that differentiates the incisive from the mental nerve. Does that make sense?
Absolutely. Absolutely. Yeah. So regarding the incisive canal, I mean, that's innervating only teeth, right? So you're not going to make the lip numb or anything going into the incisive canal.
So that's why we can do chin grafts, why we can drill right through it, and we never get neurosensory impairment, because it is not sensory to the chin, the lip, or the anterior gingiva. It in that incisive canal is a nerve, artery, and a vein. All 3 of them are together, and there are different nerve fascicles and different blood vessels to go to each tooth. What happens when you take out the tooth? That canal is still there. Without the tooth there, it becomes necrotic, but sometimes that's delayed because the body has to basically resorb it and grow new bone into it. So you can drill through it, you can cut it, you can do whatever you want, and it's not going to give you any neurosensory impairment. The only area that you have to worry about, that this lip, chin, and anterior gingiva, is the mental branch, or back in the posterior, which would be the inferoalveolar nerve.
Got it. Got it. Okay, you showed us these sublingual concavities, and you showed us that hourglass figure. That was pretty amazing. So let's say I'm trying to place an implant in the area of number 19, and I've got this big lingual concavity. Can I tilt the implant? How do I position the implant?
Did you say 18?
19. Yeah.
19. Okay. So it all depends on the concavity. So some patients have very large concavities. Other patients have no concavities. So it's on a case-by-case basis. Basically, though, I would say that it's very uncommon in 19 because of the width of the mandible is so significant. Even with resorption, you still have usually a column of bone that you can place an implant. But I want do an abnormal angulation in the first molar region to avoid that. Usually you can build up that buccal plate. Remember, the bone resorbs from the buccal to the lingual. So that's where the tooth was. So if you build up the buccal plate, you're always going to have usually enough bone. Secondly, what has changed, Neil, back when you and I started this in oral implantology, what did we want? We wanted the longest implant, right? 18 millimeter Brandmark implants. That's what everyone used. Now the design is so much better. We don't need longer implants. So shorter implants work very well. Not ultra short, but short implants, usually 7 or 8 millimeter implants work very well back there because the diameter is larger.
Right, right. Excellent. Okay. And what about modifying flap design to make sure that you're not going to impinge on the mental foramen or the nerve as it exits?
Well, that's a whole that's a whole day topic, but let me give you the Cliff Note version of it. Whenever you are flapping and near the mental foramen, the ideal area to go to, the anterior aspect, is the canine. Usually, if you want to be the safest, go to the anterior, then do a release anterior to the canine. The mental foramen is extremely variable. It depends on gender. There's an ethnic component to it, orthodontic component to it. It can be, studies have shown it can be all the way back to the molar, all the way up to the cuspid. So the bottom line is determine where the mental foramen is, extend your incision 1 tooth. Where it becomes very problematic, Neil, is when people try to release the tension of the flap and they go right over the mental foramen. Just remember that photo of those 4 nerve fibers coming out of the canal. Where do they go? They're in the soft tissue. So if you start spreading the tissue, you're going to sever those nerve fibers. Now, the good news is they have cross innervation. So even if you do sever some of the nerve fibers, it's likely it's not going to be a full-blown nerve impairment because there's so many nerve fibers, they basically re-innervate that area.
Okay. You mentioned the Y factor or the Y dimension in drills, where this is like the point of the drill going beyond the nominal length of the drill. Does the CBT and the planning software, does that understand that? Does it have those dimensions built in and will make sure you stay out of trouble?
Yes and no. Okay. I've not seen a software that is specific for the system, which ideally I think in the future it will. But let's say that system A might have a millimeter wide dimension, but system B might be a 2.5. The 2.5 are problems. That's why when we say 2 millimeters away, it's a minimum of 2 millimeters away. And so if you have one of those systems, there's not many out there anymore. There used to be a lot of them. But if you do have one of those systems with a larger Y dimension, you need to, who's ever planning your case, instead of being 2 millimeters away, you have to be 3 millimeters away. However, the generalized safety zone is 2 millimeters for that.
Okay. And if anybody is wondering what the Y dimension is of their implant system, if you go to your surgical manual, they always have a schematic showing the length of the drill, and just like Randy showed with the length. So it is part of the documentation of the implant system because it's kind of an important thing to know.
Yes. Yes.
Very good. Okay. What about situations where the cortex of the alveolar nerve is not really visible in a CT? Let's say there's some kind of abnormal bone metabolism. Have you seen that where it's just really hard? You don't really see that white line.
Yeah, actually, I didn't have enough time to go over that, but let me explain that because there's a misinformation out there. If you look at a lot of textbooks, they'll show the nerve with this nice big cortical lining around it. Okay. Studies show 38% of neurovascular canals have no cortical lining. So there's no cortical plate. So why is that significant? I've been involved in cases where doctors have done a socket graft. And what happens is they put bone down into the socket and it migrates down into the canal, and then it irritates the nerve and you get a nerve impairment. So you should always look at that. Usually where we see that, Neil, is patients who are osteopenic or osteoporotic. So usually females, you'll see that more often than males.
So
But
how can
yes,
I identify the nerve if there's really no cortex around it?
okay, that's why we have a CBCT course. So we teach you how to do that. That's something that a lot of people guess. And that's why anytime I get a case back, I'll always draw my own nerve. And the short story on it is, you know where the nerve comes in, right? You know where it leaves. Okay. So you start at those 2 points. Then you have to look incrementally for any remnant of it. And then if you go in the axial images, like I showed you with the anterior loop, you can actually point by point draw the nerve, and then you connect all the dots. That's how you do it.
Got it. We did have a question about where can they learn more, and I did mention that he's got this CBCT boot camp. It's a 1-day course. It is so much information in 1 day. I would go to the Resnik website and find out when the next time they're teaching that course. There's no better place to learn about reading a cone beam.
But we show you how to do that, because I've seen cases where the laboratory draws a nerve, they'll put the implants in and the nerve was in the wrong position. So I never trust it. I always do it myself. And there's just some basic rules, and we go through all those rules. If you can't make it to a course, it's in both of the textbooks also.
Okay. I take a post-op x-ray, and it looks like I've perforated the inferior border or the lingual plate. Should I remove the implant?
That is a problem. Because here is the issue that we're starting to see, and I didn't go into this, but because of the new design of these implants, leaving an implant outside of the bone actually has become, quote unquote, below the standard of care. So you will have someone testify against you saying that's below the standard of care. Secondly, there is cases, in fact, I was just involved in one last month, where a doctor placed an implant, perforated, left the perforation, and he used an implant that had a very aggressive thread at the very apex. Patient went home, went to sleep, started swelling up. That sublingual artery pressed against that implant. Patient moved around, got a little laceration, ended up with a sublingual hematoma. So you can have a delayed one. So to be honest with you, if you have a perforation, my recommendation would be to remove that, place a piece of collagen down in there, collagen plug, either graft over it or put a shorter implant in, but don't leave it outside the bone. I've also seen cases where in the lingual, I talked about the sublingual undercut, people perforating. It doesn't cause any bleeding issue, but if you can imagine the mucosa going over top of an implant all the time, it becomes very irritated. Patients will get ulcers, or it'll become very sensitive for them. So the bottom line is keep the implant within the confines of the bone.
Okay, so let me finish with a sort of a general question about using guided surgery. So what you've pointed out is a bunch of pitfalls, and the pitfalls can be moderated by the fact that you got this 3D imaging. But the next step is to take the 3D information and use it in your surgical procedure. I mean, does using guided surgery mitigate most of these risks?
Yes and no. Yes, the safest way to do surgery is guided, definitely. However, there is a treatment planning component to it. And I'll represent doctors all the time, and they'll go into a deposition and they'll say, what's the Y dimension? I don't even know what the Y dimension is. Well, Well, why did you perforate? Well, there wasn't enough bone, so I just perforated. So there's various factors and protocols that you have to adhere to that during the treatment planning. So you can get a guide and do it fully guided and put it into the lingual plate of the anterior or posterior mandible, which is very unsafe because you can perforate very easily. I just wouldn't do it. I would make sure the treatment planning utilizes all these principles to avoid complications. Does that make sense? So
Makes
there's
a
two
lot of sense.
components. The guided is definitely the safest, but you have to be careful on the treatment plan, that it's treatment planned right, and you know all these bad things that can happen because they do happen, and people don't like to talk about them, but I see them all the time, to be honest with you. And so
a good software program is no substitute for knowledge of dental anatomy and knowledge of implantology.
Yeah. And one more thing, Neil, remember, a patient cannot consent to, say, if they have a sublingual undercut. I'll have doctors do this all the time. Well, a patient signed a consent. They understood the risk. No, they can't. They can't consent to negligence. Perforating the bone is, in our field now, considered negligence. And unfortunately, that's that's the way our society is nowadays.
No, and that's really good information, because in the early days, hey, perforating the inferior border of the mandible, that was kind of the go-to way of doing it.
We did all the time, and I have no idea how we got away with it for so many years. It's crazy.
It took the lawyers a while to catch up with us.
Exactly.
But such great information, Randy. As always, we really appreciate it. And please, folks, we give Dr. Resnik only about 45 minutes to talk here. He has just volumes and volumes of information. So he's got his textbooks, he's got his courses. There's so many more opportunities to learn from Dr. Resnik. So we don't want to feel like he gave us everything he had today. He gave us as much as he could, giving the time that we gave him. So thanks so much, Randy. Thanks to the panel. And thanks everybody for joining us today. Now, next week, we're going to be off for the Labor Day weekend, but the following Friday, which is September 8th, we're going to have this gentleman named Randy Curran on. And Randy Curran is an expert on the financial aspects of sleep medicine. It's lots of fun to make sleep appliances, but it's even more fun when you get paid for it. And Randy is really good. He shows a couple of very simple pathways for getting paid both by insurance companies or by private payment. And he's a great guy. We had him at our sleep symposium, and I learned an awful lot. So why don't you join us in 2 weeks? Thanks again, Dr. Resnik.
Okay,
and
thank
the
you.
Panel.
Thank
and we'll
you
talk
so
again
much.
soon. Take care, everybody. We'll see you in 2 weeks.
Great job, Randy.
Okay. Thank you.